We did chest pain, we did belly pain. Oh, we did musculoskeletal trauma. So today we'll finish up with pediatrics. Good. Okay, so good to see you all. I hope you had a good day so far. I'll try not to ruin it for you. Today we're going to be talking about pediatric emergency medicine cases. I have probably the better part of a dozen cases on here. We have some semi-orthopedic cases, and we have some ENT cases, which are common in pediatric emergency medicine. So we're not going to waste any time. We'll go ahead and get started. So this is a common presentation that we see in children, and there's a couple of differentials that we will see in the child who refuses to weight bear on an extremity. So we'll start off with the case of a 14-year-old boy who presents to the emergency department with a painful limp and left thigh pain. He has normal vital signs. Left lower extremity pulses, sensation, strength, and reflexes are all intact and normal. He is mildly obese, limited left hip range of motion, and an X-ray obtained and is shown here. So these are some of the options of what we may want to do. So let's first take a look at this X-ray. Could you expand the X-ray a little bit there, or expand the image? Okay, so if you draw your attention to the right side for you folks, the left side of the patient, remember when you're looking at these films, when they're presented to you like this, left is the patient's left, right is the patient's right. Obviously, you're looking at it from a different. So this would be the patient's left hip, patient's right hip. Do they look the same or different? Which one looks messed up? Yeah, so the patient's left hip, the one that's to your right. And remember, I think we said something about this the other day when we were talking about musculoskeletal, particularly as it pertains to pediatric cases. Before you have fusion of the growth plates, it's always good to get a comparative X-ray so that you can compare the unaffected and the affected side to look for any differences. So many cases when you're ordering a film on a young person, the protocol in the radiology department is to also look at the unaffected side so you can compare. Remember the anatomy of the long bones? The diaphysis is the long part of the bone. The epiphysis is the very end of the bone. And the metaphysis is where the end and the growth plate meet the diaphysis. So you can see that in this particular X-ray, the epiphysis of this particular femur looks to be abnormal. So this is a condition that we see. It's not particularly common, but it is a common cause of hip pain. So this is going to be a case. We won't answer these questions, but this might be something that you want to consider doing a hip arthrosis, doing an aspiration of fluid in the joint. Why would you do an aspiration of a joint? What would you be looking for? Bacteria and infection, right? Septic arthritis. Before you would start broad spectrum antibiotics, you would do a hip arthrosis. Quadriceps strengthening exercises. That's if you believe that there's some type of congenital weakness in the hip or some other reason, maybe from atrophy that you want to strengthen the leg. Probably wouldn't be applicable here. Sending this child home with no further, just some analgesics would not be a good plan. And the last one is orthopedic consultation or surgical consultation. So let's see what the plan would be in this one. Probably the recommended thing to do with this case is to get a surgical consultation, an orthopedic surgical consultation. Obviously, that X-ray looked normal. This is consistent with what we call SCFE. SCFE is the mnemonic for that, and that's slipped capital femoral epiphysis. Slipped capital femoral epiphysis. It's pretty pathognomonic on X-ray. It's really hard to miss this. Early on, it can be subtle, and you can have a normal X-ray with just pain in the hip area. But when you see this degree of changes on a skeletal X-ray, the diagnosis is pretty clear. Femoral, so you see that epiphysis slipping, more common in boys than girls, adolescents. Usually the child may be a little bit overweight, and it's secondary to repetitive minor trauma. In other words, too much repetitive stress on that growth plate of that femur. Complications, if not addressed quickly, can cause avascular necrosis. Remember, blood supply to the femoral head comes from the metaphysis. So if you have a disjointed epiphysis or the head is slipping, it's going to affect the blood supply. You can have acute, chronic, or acute on chronic. They're all going to present a little bit differently. Generally, they have difficulty bearing weight. They may be able to ambulate, or they may not want to put no weight on the leg. And anything having to do with the hip joint can present with hip pain, groin pain, thigh pain, knee pain, even buttock pain. There's a lot of innervation in the hip area, and it can give you referred pain outside of the hip specifically. They'll usually present with an abnormal gait, external rotation, and again, the X-ray is pretty commonly diagnostic. It's the most common hip disability in adolescents. You need to consider this and order the appropriate X-rays. Management is limited weight bearing, some analgesics, but most of these are going to end up with a surgical repair. They don't just go away once they've gotten to this degree. There's a schematic here which shows you the Klein line. You can see it right here. This is normal, and it should bisect the lateral aspect of the epiphysis. In someone that has a slipped epiphyseal head, you're going to miss that. That's an abnormal Klein line. Again, diagnostic by X-ray, management, non-weight bearing, and operative stabilization with pinning. The earlier you catch this, the better. In some kids who will present and they just don't want to walk on the leg, or they're favoring the leg, you may get an X-ray and it looks normal, but you still need to consider this as an early pre-slip presentation of this. So SCFE is the name of this. It's a good question for when you're doing your pediatric rotation or you're having a pediatric in-surface exam. They're going to probably present a case like this. This does not require a hip arthrosis. Not a lot of reason to do any significant quadricep strengthening. It's not going to resolve this. Osgood-Schlatter disease, that usually affects the lower leg, just below the patella, and urgent surgical management. We'll do another limp case. There's 2 or 3 of these so you can see the differential diagnosis. So here we have a younger child, a 4-year-old boy, brought to the ED for right hip pain for the last 3 days. He's been walking with a slight limp. On exam, he has minimal pain with passive movement of the right hip. You'll note that the clinician is concerned about what's called transient synovitis. We'll explain what that is, rather than septic arthritis. So there's a couple of things. With transient synovitis, and we'll explain to you what that is, you should have a pretty normal X-ray. The SED rate should not be elevated. The SED rate is like a poor man's marker for inflammatory disease or inflammatory process. In a septic arthritis, the SED rate's going to be high. Normal is 0 to 10, maybe up to 20, depending on your age. Certainly a SED rate of 50 is 2.5, 3 times normal. That would be too high. If you had a high SED rate, you would be thinking more of a septic arthritis. Oral temperature of 36.8 correlates to 98.2 degrees. So this child would be afebrile, which is what you would expect in synovitis, and you would not expect to have an elevated white count. So the thing that would be most consistent with transient synovitis is a normal temperature. You should not have an elevated SED rate. You should not have an abnormal radiograph, and your white blood cell count should be normal. Remember, we said the normal range on white count, essentially 4,000 to 10,000. In kids, it can go up a little bit, like 12,000, but 20,000 would certainly be a little bit too high. So what is transient synovitis? It's the most common cause of acute hip pain in children between the ages of 3 and 10. Inflammation of the synovium of the joint. Ultrasound may show a joint effusion. You can see here, remember, black is either air on an x-ray, but on a ultrasound, black is fluid. So you can see there's an effusion just above the femoral head there. That means there's fluid in the joint. With the absence of a fever and a normal, so the absence of a fever, no elevation in the sed rate, no elevation in the white count, you would not necessarily need to consider septic arthritis. You would not need to do a hemarthrosis of this, or an arthrocentesis rather. You can treat this with anti-inflammatories, and it's typically going to resolve on its own. It's usually preceded by an upper respiratory infection, a viral infection in a young child, 3 to 10 years of age. Pretty much what we just talked about here. So no x-rays necessary. Sed rate's usually going to be normal. White blood cell count, if you do one, should be pretty normal. And most common cause of acute onset childhood hip pain. So we got 2 so far. Transient synovitis, remember, no fever. Generally goes away in a couple of days. Give them a little ibuprofen. That first one, SCFE, the x-rays, pathognomonic for it. That's a serious condition. They're going to need operative repair. So we have another case here of 2-year-old boy brought to the ED because he refuses to walk for the last 2 days. Blood pressure 90/40. That's okay for a 2-year-old, 90/40. Heart rate of 140, that's elevated. Respiratory rate 24, mildly elevated, but not too bothersome. And an oral temperature of 39.2. That equates to about 102 and change. So elevated temperature, mild tachycardia, hip pain. He's holding his left hip flexed, slight abduction, abduction. Do you guys remember the difference between abduction and adduction? I always kind of get a little confused about it, but I remember adduction, adduction, you are adding it to the body, so it's towards the midline. Abduction is away from the midline. So this is a child that would have his left hip. Somebody say? Question? No. So this would be a child that would have hip flexed, slight abduction, and external rotation. Pain with passive movement of the left hip. Blood work is significant for a white count of 13,000. That's mildly elevated. Most likely diagnosis in this case with that fever, mild tachycardia. We'll explain what leg calf Perth disease, and it's essentially aseptic necrosis of the femoral head. So septic arthritis clearly is in the differential for this kid. Fever, refusing to walk on a joint. SCFE, he shouldn't have a fever with that. And usually it's not a 2-day. You could have an acute SCFE, but x-ray would be diagnostic on that and shouldn't have a fever or shouldn't have a tachycardia with that. And transient synovitis, again, should not have a fever, should not look systemically ill. So this is likely septic arthritis. Staph is the most common offending organism in a child like this. Usually it's secondary to hematogenous spread. That means infection elsewhere, seeds the bloodstream. Remember what I said the other day? Shaking, chills, rigors is bacteremia till proven otherwise. When you have a dental procedure or you have a urologic procedure, you can get transient bacteremia. That's why patients with some prosthesis or cardiac valves that have dental or urologic procedures, they're going to have transient bacteremia. So that's why you prophylax them with antibiotics. So in children, staph is the most common, and it's usually due to hematogenous spread from a secondary source of infection. It can be from trauma, or it can be from a post-surgical infection. More common in males under the age of 4. Acute onset of fever, irritability, refusal to weight bear, warm, erythematous, swollen. You probably should get a arthrocentesis done before you begin antibiotics. Usually this is ultrasound guided arthrocentesis or fluoroscopic guided arthrocentesis. They'll do this in the interventional lab, where the orthopedist will assist with this. It's difficult to do if you have not been experienced in it. So we would usually call one of our orthopedic colleagues to come in and tap the joint. If there was going to be a delay, we would just do a blood culture and start antibiotics right away. Pretty much what we talked about. The last thing you'll see there are in septic arthritis, you'll see greater than 50,000 cells on microscopic examination of the fluid. Glucose is decreased. A little just thing to remember, whenever you have a bacterial infection in a fluid source, the glucose is going to be down because the bacteria is eating it up. Glucose drops. It's also producing proteins as a byproduct of its pure existence in the joint, so your protein is going to be up. So bacterial infection in a fluid sample, glucose down, protein up. Start on antibiotics, surgical intervention. Sometimes they need to have, if it's not responding to antibiotics. Remember we said the other day, any closed space that has infection, sometimes antibiotic alone don't work. So sometimes the joint has to be aspirated and lavaged and cleansed out. Sometimes that requires open surgical intervention to wash out the joint. And then consider Lyme disease. When Lyme first started, I'm from Connecticut. Lyme was first recognized in Lyme, Connecticut. We'll talk a little bit about Lyme disease next week when we talk about some of the tick-borne illnesses. But there was a predominance of what they were diagnosing as juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis can typically affect the hip or the knee, and there was an exaggerated amount of juvenile rheumatoid arthritis diagnosis in this particular area. And when they did their research and did further investigation, they realized it was much more of an infectious process rather than a true rheumatologic process. So anybody with a painful, swollen, monoarticular arthritis, hip or knee, consider Lyme disease in your differential, and you should be obtaining a blood, Western blot for Lyme disease. There's something called the Kocher criteria, which you can see here. It's basically a scoring system, and you can see, so in this case, non-weight bearing on the affected side, yes. Let's say the SED rate, I think we said it was 50 or was elevated. Let's say the SED rate was elevated. We know the kid had a fever. White count was 13,000. That gives him a score of 3 or 4, depending on what the SED rate was. That gives him about a 93% chance, at least, of this being a septic arthritis. So you can feel pretty comfortable. Go ahead and initiating antibiotics. If the answers to those questions were more predominantly no, then you're dealing much more with most probably a transient synovitis. Leg calf Perth disease. And again, this is something that when you're doing your pediatric rotations and there's the end of the rotation in-service exam, they'll often ask about the difference between SCFE and leg Perth disease. This is basically aseptic necrosis of the femoral head. Males between the age of 3 and 12 present with a limp, much more insidious in nature, associated with pain, referred to the groin. Remember, hip pain can refer to the groin, the thigh, the knee, the buttock area. It's generally treated with restricting activity, anti-inflammatories, bed rest, sometimes traction, casting, depending on the age. It's a difficult condition to treat, and ultimately, if not diagnosed early enough, these kids will go on to have an early hip replacement. Considering hip replacements usually only last about 20 years, to see this in a young person, they're going to probably have to have multiple surgical procedures over the course of their life. If you fail to diagnose it, you're going to get shortening of one leg, and you're going to have gait abnormalities and other problems associated with one leg being shorter than the other. So we talked about 3 different or 4 different transient synovitis, SCFE. We talked about septic arthritis. So when a child comes in with limping, refusing to bear weight on a leg, those are a couple of things that need to be into your differential. And again, take that history in a little kid. If a under 2-year-old's refusing to weight bear on a leg, remember we talked about Consider child abuse, depending on if there was or wasn't injury. If you have fractures, consider child abuse if there's not a good story as to why a child should have a long bone fracture. And again, the most common cause of that septic arthritis is hematogenous spread. Just a slide comparing the different conditions we talked about. Okay, let's shift from the lower extremities. We'll go up to the ear, nose, and throat area because, again, common complaints from the pediatric population having to do with head and neck complaints. A 14-year-old boy presents with ear pain and fever. Examination reveals a bulging erythematous tympanic membrane and post-auricular, behind the ear, erythema and tenderness. Which of the following is the most appropriate management strategy? So, couple of things here in the history that concern you. Ear pain and fever. Okay, it could be an otitis media or it could be a viral illness or something. A bulging erythematous tympanic membrane, usually consistent with fluid in there. If you're good at examining ears, you should also see if the eardrum has scarring or if when you insufflate air, if the eardrum moves. A lot of times your otoscope will have a little bulb on it and you can give a little jet of air in there, and the normal response of the eardrum is that you can see it flex a little bit. If you don't see that, that means either there's some scarring or maybe there's some fluid behind it. You should also be looking for perforations in the eardrum. But this post-auricular erythema and tenderness is a little bit concerning. So in children that maybe don't have access to medical care or there's a delay in diagnosis of an otitis media, you can sometimes worry about other structures involved. This would be a case where you certainly wouldn't want to put some eardrops in this kid and send him home. That's for usually an otitis externa. Oral amoxicillin and recommend follow-up with primary care. It might be if you just thought it was an otitis media, but that erythema and post-auricular pain and tenderness and swelling is more concerning for other conditions, possibly acute mastoiditis, which can be a big problem. There is a situation where if you believe symptoms are mild and you think this may be just due to a viral otitis media or a middle ear infection, secondary to a virus, there are some recommendations that you give the parent a prescription for an antibiotic. You say, just don't fill it right away. Wait a day or two. If little Johnny gets better and the symptoms go away, this was probably a viral illness. If he develops a fever, conditions worsen, then you can go ahead and initiate the antibiotic therapy. That would be somebody where maybe you were concerned about follow-up, somebody that you were going to see once and concerned about follow-up. Maybe they didn't have access to aftercare. So that might be an option in some cases. So let's just see what this case looks like. So this case, because of the erythema and the pain behind the ear, consider acute mastoiditis. This is a child that you'd have some further evaluation. Typically, you're going to do a CAT scan looking for fluid in the mastoid air cells. That patient's going to receive a broad spectrum cephalosporin like ceftriaxone or Rocephin and admit the patient for further care to the pediatric service. Generally, it's going to be a strep pneumoniae is the most common, but in immunocompromised or depending on the age, you can get other conditions. H influenza used to be more common, but now with the H influenza vaccine, we don't see that as much. Pseudomonas, more common in diabetics. Well as protrusion of the auricle. So the ear, you'll get some asymmetry in appearance. You'll look at them and one ear seems to be pushing out a little bit more than the other. Antibiotics, probably some imaging, again, a CT scan, and close follow-up, because this can sometimes require surgical intervention. A little schematic looking at what acute mastoiditis looks like. And you can see otitis media, untreated, it's very close to where the mastoid air cells are. It's not It's not common in patients with otitis media because generally patients will have access to antibiotic care, but if there's a delay in treatment and the child has recurrent otitis media, you need to consider mastoiditis if their conditions worsen. Complications of mastoiditis include meningitis, epidural or subdural abscess, facial nerve palsy, hearing disequilibrium, bone infection, venous sinus thrombosis. So you really don't want to miss this case, so you need to be fairly aggressive with it. And most common cause of viral illness, since we were talking about RSV. Similar, under the age of 6, RSV is going to be your most common viral illness. Actually, RSV is making a comeback in adults as well now. Now they have an adult vaccine for RSV. If you're over, I don't know if it's 65 or 70, they're recommending RSV vaccination as well. Okay, we'll do another ENT case. Just keeping an eye on the time here. So this is a 10-year-old boy who presents with a 2-day history of sore throat, fever, and headache. Absence of a cough, that's important. Absence of any rhinorrhea, runny nose. Absence of head congestion. So isolated sore throat, fever, and headache. PE is remarkable for enlarged erythematous tonsils with a pharyngeal whitish exudate. Marked lymphadenopathy, anterior and posterior cervical lymph node chain. Which of the following is most likely diagnosis? So we'll start at the bottom, tonsillithiasis. That's from chronic tonsillitis, and you get inspissated secretions. You almost get some small stones that form and block some of the drainage of the tonsils. Remember, tonsils are essentially lymph nodes that help fight infection. So chronic infection can give you chronically enlarged tonsils. Sinusitis, absence of head congestion and rhinorrhea, and so it doesn't really sound like a sinusitis. Mononucleosis. How old is this kid? 10. What's the peak ages of mono that we think about? Usually typically older than that. Anywhere between the age of 16 and 25, 16 and 40, think mono. Usually in young kids like this, maybe a little bit too young for mono. And infectious mono also has a much more indolent course. Usually the child has malaise, fatigue, low-grade fevers, mild sore throat, and it progresses over several days before they become symptomatic enough to seek medical care. So certainly bacterial pharyngitis is a concern here. The cervical, anterior and posterior adenopathy is concerning. Exudate on the tonsils. Although not pathognomonic for strep, you can get exudate with viral pharyngitis as well, but the combination of enlarged lymph nodes, headache, and exudate is strongly suggestive of bacterial pharyngitis. So how do we know for sure which this is? There are some scoring mechanisms that we can use, again, to help differentiate it. A lot of it is your clinical experience in being able to recognize this, but not every kid with a sore throat has strep throat. But most commonly, bacterial pharyngitis is caused by Streptococcus, inflammation of the pharynx, tonsils, fever, malaise, sore throat, absence of URIs. If a child has a pretty bad cough, that kind of actually goes against a strep throat. Child has a runny nose, that goes against a strep throat. So in the absence of rhinorrhea and cough, much more likely to be a streptococcal pharyngitis. Anterior cervical lymphadenopathy is often found on exam. Just as a sidebar, on infectious mono, you'll also get cervical adenopathy, both anterior and posterior, as well as potentially splenomegaly, which we'll talk about in a second. White exudate over the pharynx and the tonsils. There are these rapid strep antigen tests that you can do, a quick strep swab. Generally about 90 to 95% accurate for the quick strep. If you have somebody that has clinically, it looks, tastes, and smells like strep, and you do the quick strep and it turns out negative, it means a couple of things. Either A, they don't have strep, B, you didn't get a good sample, or C, it's one of those 5 to 10% where the test just didn't turn out positive. And sometimes clinically, even with a negative quick strep, I'll initiate treatment and then we send that swab for a formal full culture. about 90% sensitivity we talked about. Complications of untreated streptococcal pharyngitis, acute glomerulonephritis, peritonsillar abscess, bacteremia, possibly seeding a synovial joint, sinusitis and pneumonia. Generally, penicillin-based antibiotics, cephalosporins, or penicillin-based are treatment of the choice. We don't use a lot of straight up penicillin anymore. Most kids that have we suspect pharyngitis, they end up getting amoxicillin or one of the cephalosporins. But if you're fairly certain it's a strep pharyngitis, penicillin works great. And it's cheap and fairly easy to take. In somebody that has recurrent bacterial pharyngitis, in a child, you can sometimes give them a one-time injection of benzathine penicillin and then be done with it. Particularly in somebody that you might think, are they going to take it for the whole 10 days or are you going to lose them to follow-up? Some of those kids that maybe failed treatment, you're going to give them a shot. So you always have to stress people too, once you initiate antibiotics, whether it's for an otitis media or a pharyngitis, tell them to take it to completion of therapy. A lot of times the patient will start to feel better in 2 or 3 days and they say, okay, I'm done. I'm going to save that antibiotic for the next time I get sick. Tell them to take it all the way to the end of treatment there, because otherwise you get recurrence and then more associated complications. Penicillin allergy, you can use the macrolides, azithromycin, erythromycin as an alternative. Again, these are all usually going to be gram-positive cocci, strep. A schematic of what strep pharyngitis can look like. This is you can see the uvula in the midline there with the exudative tonsil, bilateral tonsillitis. We're going to talk a little bit about peritonsillar abscess here. Peritonsillar abscess is always in the differential of somebody with a bad sore throat. Couple of things with peritonsillar abscess. So let's say you had somebody who had a sore throat for 3 or 5 days. They just weren't getting better. They didn't go see anybody. And all of a sudden, condition worsens. They have a fever. In peritonsillar abscess, because of the location of an abscess on the trismus muscle, they have difficulty opening their mouth. Kid with strep, usually they can open their mouth and get a good exam. Somebody with peritonsillar abscess, one of the things to tip off is you ask them to open their mouth and they can barely open it, maybe only a half inch or an inch, and you really can't get a good visualization. That's a key that you should be thinking peritonsillar abscess. Yes. Yeah. Peritonsillar abscess is going to be unilateral. So again, this is that picture we see there. That's pretty symmetrical. You see the uvula in the midline there. In peritonsillar abscess, it's going to be unilateral and the uvula will be deviated. I think I have a picture of that coming up there. You can see the antibiotics we talked about, penicillin, cephalosporins, clindamycin, macrolides. Clindamycin is a great drug, but about 10% of patients who are on clindamycin or Cleocin can develop a C. diff colitis. So clindamycin is a great antibiotic, but again, about 10% of the cases can end up with C. diff colitis, which you really don't want to have to deal with. Macrolides, erythromycin, azithromycin. Mono, just a couple things. Age, a little bit older, 15 to 24. I like to say up to 40. That's due to the Epstein-Barr virus. Usually there's a several-day prodrome for that. Treatment is supportive. They don't need antibiotics. Splenomegaly. You should not normally, even in a thin person, you should not normally feel a spleen tip when you do an examination in the left upper quadrant. It's abnormal to feel a spleen tip. So when you tell a patient you're examining them, their abdomen, you're looking for hepatomegaly, splenomegaly, when they take a deep breath in, if you feel their spleen, that's potentially a little bit enlarged. So in the face of potentially a pharyngitis that could be infectious mono and an enlarged spleen, that's concerning. We've had cases where people have had infectious mono, enlarged spleen. They're playing contact sports, football, hockey, what have you. They take a hit to the left upper quadrant, cause a splenic rupture. So one of the things we will tell parents once we've diagnosed infectious mono in their teenager, their active teenager, typically they start feeling better after a week or two. Splenomegaly may take 3 to 4 weeks before it will actually go away. Again, the spleen is like a big lymph node there. So it's fighting infection. It's going to be enlarged, much more prone. So usually we tell those kids, No significant physical activity or contact sports until, number one, there's no palpable spleen, or you're at least 3 to 4 weeks out from diagnosis. You can do a simple blood test. It's called a monospot or a heteroviral antibody, and you get the diagnosis right away. If you don't have access to that test, a CBC, you'll see a lymphocytosis. Remember we said yesterday, I think we said with a bacterial infection, you see a lot of leukocytes, you see a lot of immature, what we call bands, bandemia. Remember, the marrow is pushing out those the polymorphonuclear cells to try and fight a bacterial infection. In an Epstein-Barr virus infection like infectious mono, you have a predominance of lymphocytes and atypical lymphocytes. So you may get an elevation in the white count, but it's going to be a lymphocytic shift. Treatment supportive. If splenomegaly, no contact sports. And if you see a kid and you don't have access to a strep test and you say, this looks like strep pharyngitis, you put them on amoxicillin or ampicillin, 90+% of the time, if it's mono, they're going to develop a rash. They're going to develop a diffuse rash, a morbilliform rash, and that's pretty much diagnostic of mono. It's not the same as an allergic reaction to a penicillin, so it's not hives. It's a drug eruption secondary to the combination of amoxicillin and infectious mono. Don't ask me why. It's just that it's going to happen probably 90% of the time. There wasn't much here to suggest sinusitis in this case. I will say just a quick word about sinusitis in the pediatric population. Can be caused by viruses, but if it's prolonged, protracted, they have sinus pain, they have a fever, they look sick. Maybe if you do imaging, they'll have lots and lots of fluid in their maxillary or their frontal sinuses. Those are going to require antibiotics, and you typically need to treat them for 2 to 3 weeks if you really have a bad sinusitis or a pansinusitis. Organism, H. flu, strep, Moraxella. In kids, think foreign body in the nose. So you have little kids, I don't know. They like to stick things up their nose beyond just their finger. So I've had kids with everything, Tic Tacs, Good and Plenty, beads, Legos. And, you know, a lot of times it'll just disappear up there. You won't see it. Mom or dad won't know it's there. The kid won't really be complaining about anything. And then they'll develop a sinus infection. So it does behoove you, if you have a kid with suspected unilateral sinusitis, try and visualize up the nose as good as you can. And if you see in foreign body, we've seen peanuts up there, everything. If you see a kid with a foreign body up the nose, you got to get that out. Again, otherwise, again, like we said, you can put them on antibiotics. It's not going to get better. There's a cool little tool. It's like a little tiny catheter syringe that has a little balloon like a Foley catheter at the end. You can get that if you can slip it around the foreign body. You inflate 1 or 2 cc's into this little balloon, and then you can pull it out like that. There's a really cool technique also that you can tell parents to do if they're like, I don't want to put that kid in my kid's nose. You know, I'm so scared, and the kid's all over the place, and he's a nervous wreck. But you know he's got something up there. You can see like a little bead or something like that. You can tell the parents. It's almost. You tell the parents, okay, you can try this one thing. If this works, then we don't have to do anything invasive. You tell them to occlude the unaffected nostril of the child. They cover the child's mouth with their mouth, and they blow forcefully. And usually this foreign body will come out and land right on the parent's cheek with a little ball of snot around it. So I always give the patient's family the option to do that. I don't do that personally myself to them. I'll use the little pipette. But if the parent wants to try it, it's quick and easy. We talked about tonsillitis. So infection mono, we talked again about, it can look pretty similar. Tonsillar exudates, atypical lymphocytes on smear, and large spleen. Avoid contact sports. We talked about sinusitis, frontal sinus, maxillary, ethmoid, sphenoid. Again, usually you're going to have tenderness over the sinus, redness, fever. They're going to look pretty sick. You need to treat that with antibiotics. Just a word about tonsillectomy. They used to do tonsillectomy much more frequently than we do now, because we've realized that unless criteria is met, taking the tonsils out actually leads to more upper respiratory infections and bacterial infections down the road. So you try and leave the tonsils intact, and there's some scoring systems here you can use. Somebody has more than a half a dozen episodes in the past year, or 5 episodes per year for 2 years, or 3 for 3 years. It's just, if you have cumulative infections, much more likely to need a formal tonsillectomy. If again, putting kid on multiple antibiotics, what's that going to do? It's going to affect the microbiome. There's a lot of talk now about the importance of gut microbiome in normal health and maintenance of health. For a child that's had multiple prescriptions and courses of antibiotics before the age of 2, it's associated with chronic inflammatory disease because of disruption of the microbiome. I mean, that's another thing with, cesarean section, born by cesarean versus vaginal birth. There's a lot of benefits of a vaginal birth with developing the bacteria that's in the normal vaginal canal that helps with the microbiome of that growing child and helps prevent chronic illness down the road, versus a cesarean section where that child doesn't have the advantage of exposure to those bacteria in the birth canal. You'll probably be hearing a lot more about that over the next number of years. There's a book I'd recommend. It's called Blind Spots. If you're ever looking for something to read on your time off, Blind Spots. It's by a Marty McCary from Johns Hopkins, and it talks about these things that we learned that that maybe they weren't really based on really good studies, but they just got incorporated into medical treatment. One thing that comes to mind, I'm deviating a little bit here, but it's really important, is the development of peanut allergies. We used to say, don't give peanuts to kids before the age of 2 or 3. And because we thought that the number of peanut allergies was increasing. So we said, don't give it to kids before the age of 2 or 3. That's the complete opposite of what should be done. You should have early exposure in small amounts to peanuts so that you do not develop. It's basically a sensitization so you don't develop it. The United States has the highest incident of peanut allergies because of that recommendation by the American Academy of Pediatrics maybe 18 or 20 years ago. And just now they're starting to try and undo that. But we've created this vicious situation where now your kids in the States, I mean, you can't even bring peanuts into the classroom in their snacks, or, you can't have kids over to a party, a birthday party to your kid's house if they're little and have peanut things. Schools don't allow it, et cetera, et cetera. And it's not because the parents did anything wrong. They were following the recommendations of the American Academy of Pediatrics. You go to other countries where some of the food products early on contain peanuts, and there's no peanut allergies in those areas, or it's very, very rare. So if you're ever looking for just it's an easy read, and it's just something that'll just open your eyes, help open your eyes up to things that we do sometimes that you need to question. We talked about that general pharyngitis. Let's get to another. Well, here's the Centaur criteria. Again, this is a scoring system to see if it's likely strep or not strep, and it helps give you recommendations as to how to proceed. So in the modified Centaur criteria, you can see the higher the score, the more likely it is that it's going to be a strep infection, and you can treat them empirically versus low probability, no test, no treatment necessary. And then the mid-range, you may want to recommend a rapid antigen test and hold treatment until you get results of that. Okay, I think we mentioned peritonsillar abscess, so we'll have a case of that. This is really talking about peritonsillar abscess and draining them and what the best technique is. So we'll go through that a little bit there. It's a little nerve-wracking to stick a needle in the back of somebody's throat, but when you have a peritonsillar abscess, it really is therapeutic. They feel much better when you can relieve the pressure in that. Remember, we said peritonsillar abscesses, it sits on the trismus muscle, or the one of the pterygoid muscles, and the kid doesn't want to open their mouth, so they have what's called trismus pain opening the mouth. So this is, if they come in, won't open their mouth, you got to think about peritonsillar abscess. The uvula is usually dilated or deviated rather. Unilateral peritonsillar swelling. Diagnosis is made clinically. You can see that when you have a peritonsillar abscess, if you look at the schematic here on the right, you'll see that the unilateral swelling, uvula may be deviated slightly. Those can be drained with a small gauge needle. You just don't want to go too deep with that because the carotid artery sits posterior and lateral to that. So it's never a good idea to stick a needle accidentally in the carotid artery. You can't apply pressure and you can have bleeding complications. So what we can do is we locate the abscess. You can anesthetize the area, or you can give the patient some opiate analgesics to make them a little bit more comfortable. You never insert the needle more than 1 centimeter. You can put what's called a needle guard on there so that prevents you from going too deep. You can see that in the schematic on the right. Superior pole in the abscess, because this is the most commonly area where you're going to get adequate drainage. This next one here. 17-year-old male wrestler presents to the ED due to ear pain and swelling for 24 hours after being struck in the right ear. Examination is significant for normal vital signs, normal middle ear exam. You want to examine, make sure there's not a perforation in the eardrum, and swelling of the helix or the auricle of the ear, and the entire scapha with loss of normal ear contours. Which of the following is the most appropriate management of this patient? So what does this kid have? This kid has auricular hematoma. So a bleeding into the space of the ear. If you fail to treat this properly, they're going to get a subsequent deformity of the ear called cauliflower ear. You see this if you watch any MMA on TV, or if you watch any college wrestling. A lot of those kids, a lot of those young men will have evidence of prior auricular hematomas, and they'll have a little bit of a cauliflower ear. My son Jesse, was a very competitive wrestler, and he had this once. We were able to drain it and then pack the ear, and his ear looks fine now. So let's see what this looks like here. Typically, you're going to drain auricular hematoma with an incision. You can, if it's not too big, you can use an 18 gauge needle and aspirate it. But if it's more than 24 hours old, there's a good chance that there's a clot in there, and you're not going to get a lot by aspirating it with a needle. So sometimes you have to make an incision in the auricle and drain the hematoma. So fighting sports like MMA, wrestling, anything where you're going to have rugby. You see those rugby players that always have the tape around their ears. That's because they've probably had this before. They can accumulate pretty rapidly. You have to evacuate these, otherwise you can get a cauliflower ear. So it's a superficial incision, drainage, and then you put a clean dressing. You have to put a pressure dressing on it, otherwise it's going to just reaccumulate. So after you've made the incision, you clean it, you evacuate the clot, and then you have to put a pressure dressing over that to prevent that hematoma from recurring. And immunocompromised patients should be given prophylactic antibiotics. Pseudomonas is common in some of these patients that are immunocompromised, particularly patients with diabetics or immunocompromised medications. Compressive dressing is important. Small bore needle aspiration, you can try it, but if you don't get fluid out, then you need to make an incision. And there's no benefit to just putting topical Bactroban on it, because that's not going to make this better. As a matter of fact, when you have a puncture or you've done an aspiration, I like to leave that open to drainage. I don't like to put it with an occlusive petroleum-based medication. So here you can see an auricular hematoma there, likely to have cosmetic deformity, requiring an incision. On the right there, the right of that schematic, you can see the deformity in untreated auricular hematoma. In trauma, ecchymosis behind the ear, also associated with basilar skull fracture. So if you have somebody who has maybe a reasonably high fall, land on the side of the head, and come in with a lot of swelling and auricular hematoma, but it's from a fall or a significant trauma, and if they have bruising or ecchymosis behind the ear, consider basilar skull fracture. Those patients need a CT scan. But again, that's more significant trauma. Okay, we got time for one more case here. A 6-year-old boy is brought to the ED by his parents for fever and neck pain. Okay, bad combination, fever and neck pain, right? Temperature is 103.1. It's pretty impressive. Oral pharyngeal exam is negative for tonsillar hypertrophy or exudate. He does have neck pain and fever, so you would have thought maybe you'd have a little strep or something like that. What exam finding would suggest a retropharyngeal abscess? Retropharyngeal abscess is not particularly common, but it's a diagnosis you definitely don't want to miss. So these kids are going to present. They're generally going to look pretty sick. This kid has a high fever. He's got neck pain, probably got difficulty swallowing, having a little bit difficulty handling his secretions. And usually this is over a course of a couple of days, and maybe they had a previous or maybe they had a previous throat infection prior to this. So what exam findings would suggest a retropharyngeal abscess? Just kind of starting at the bottom, tympanic membrane should look normal. Tracheal deviation, not really. Resistance with neck flexion, maybe. Pain with neck extension, maybe. Again, so we'll see what this looks like. Neck extension is much more likely to cause pain. Think of this: if a child has a high fever, the neck or the throat exam doesn't look that abnormal, hurts when they put their head back. Think of retropharyngeal abscess. Usually starts with an upper respiratory infection, usually not due to trauma. It can be if there's been instrumentation or had a procedure done. Clinical findings: sore throat with a pretty normal looking throat exam, fever, dysphagia, difficulty swallowing, odynophagia, which is pain with swallowing. Again, trismus and pain with range of motion, trismus being difficulty opening the mouth, decreased range of motion with neck extension, dysphonia, their voice sounds a little bit funny, and they're going to have anterior cervical adenopathy. We'll show you what a soft tissue x-ray of the neck looks like in a second. If you see gas or air in the soft tissue, that's an ominous sign. You're going to see some increased thickness in the prevertebral space. The space between the esophagus and the vertebral structures is going to be enlarged. Generally, a CT scan with contrast is the study of choice. Show you what an x-ray is going to look like. So retropharyngeal infection abscess, you can see the esophagus there and the space there. The danger space is that green area that you see there. The retropharyngeal space is that orange, and the esophagus is anterior to that. So any thickening in those spaces is going to be an area where you can develop an infection. And one of the reasons why it's so dangerous, it can progress to the mediastinum. Most common in young children. They'll present with that sore throat, dysphagia, trismus. They may or may not have some stridor. There's a couple of other conditions that can give you stridor. We'll just jump to those right here. Here's an example of that retropharyngeal space that you see, some widening of that. That's clearly a large space when compared to normal. These kids are going to require IV antibiotics, and they may have to have a drainage procedure. We'll show you the differential. Croup is common. What is it? Has anybody either had a kid or seen a kid with croup? It's pretty, once you hear a kid with croup, you can't miss the diagnosis. It's that barky seal cough, usually affects the kids at night, usually wakes them up. You hear them, with that barking seal type of cough. Usually it's caused by a parainfluenza virus. And if you can take them out in the cool night air, you can put them in a steamy shower, a bath with steam, that will usually get it to resolve. If they present to you in the emergency department, we'll give them humidified air, and we'll probably give them a little short course of some steroids, usually a single dose of Decadron or something like that. This is what the x-ray would look like with croup. It's called the steeple sign. And you can see that little black area there in the middle that kind of goes to a point. That's the airway. And you get this narrowing of the airway into a steeple. Kids with croup they can be scary. It can be scary because the kid gets all excited and they're crying and they're barking like a seal. It's really not particularly dangerous, and kids generally do fine with croup. So a lot of it is parental reassurance. A couple of things you should tell the parents too. This is probably going to happen every night for the next 2 or 3 nights. So don't be afraid. Cool mist humidifier in the room. Again, we usually give them a single dose of Decadron, which is going to last for 2 or 3 days, or you can give them a prednisolone, another steroid, daily for 3 days. I like to just give them 1 dose and get it done with. Usually you make this diagnosis without even doing an x-ray. You might do an x-ray if you were considering that it might be an epiglottitis, which is a much more serious infection, typically a bacterial infection. I think we might have so here's if you look at the lateral x-ray here, look at the lateral x-ray, the thumbprint sign is what you would see with a epiglottitis. That's a fat and thick epiglottis. You can see it here, a swollen, inflamed epiglottis. That's an endotracheal tube that's going into the airway there. In somebody that's a normal one above that, if you suspect epiglottitis, and typically these kids come in, they look sick. They're tripoding on the bed, their head is forward, they're drooling, they have a fever, they have stridor. It's scary, and the child is scared, and they're held in a certain position. You don't want to agitate them. You don't want to go sticking anything in their mouth and maybe cause them to get more agitated and have an occlusion. So if you if you strongly suspect epiglottitis, we sometimes don't even do an x-ray because you're going to get 1 shot at protecting that airway and intubating this child. So usually we'll have ENT or anesthesia on standby, whoever the most experienced operator for intubation, and we'll do that, and we'll take the patient either up to the operating room or in the ER with your consultants there to secure the airway and visualize the airway. You can generally, in a child who has epiglottitis, you can kind of override the swollen epiglottis with positive bag ventilation if you run into a real problem. But the safest thing is a controlled examination, and if needed to, securing the airway, and obviously starting antibiotic. These are typically going to be H flu, strep, staph. Again, with the H influenza vaccine, we see much less of this than we used to. You can also see this in adults. It's typically a condition that we see in children, but you can see this in adults. We've had adult epiglottitis present to the emergency department, and they're generally pretty ill appearing as well. Again, schematic of the thumbprint sign of the epiglottis on the left-hand side versus the right in that lateral x-ray where you can see a normal thin epiglottis. They typically are not going to have a lot of neck swelling. They're going to have pain with swallowing, drooling, and respiratory distress, stridor, retractions, fever. It's going to be pretty impressive when you see them come in. So we talked a little bit about peritonsillar abscess. We talked strep pharyngitis. We talked retropharyngeal abscess. And we talked epiglottitis and croup. So you can see the differential diagnosis is pretty broad in somebody that presents. You're never going to get in trouble by missing a viral pharyngitis. They go away on their own. Mono, you don't want to miss because of the spleen. Strep, you don't want to really miss because of sequelae and kidney damage, right? Retropharyngeal abscess, that's kind of an emergency. Croup, they're going to kind of get better on their own, but you don't want to miss an epiglottitis. And I think we will Why don't we stop there? It's 4:20. So we talked a little bit about lower leg problems. Remember, transient synovitis, very common in little kids. Septic arthritis, a little bit of an older group. Hematogenous spread, staph, most common. They're going to look sick and they're going to have a fever, sed rate, et cetera, et cetera. SCFE, usually heavier kids, maybe in that 10 to 15 range. Aseptic necrosis of the femoral head, that's more of an indolent course. Lyme disease, don't forget about that. And then as far as head and neck infections, otitis media, pretty straightforward. Otitis externa, you're going to typically, that's swimmer's ear, you're going to treat that with drops and they're going to generally get better. Diabetics can get chronic otitis externa. They need oral antibiotics, usually a quinolone for that, because Pseudomonas is the most common infection with that. We talked about the various throat infections, sinusitis, consider foreign body in little kids. Okay, I think that's enough. You guys have a great weekend. And for those of you that are around on Monday, we'll see you on Monday. We're doing wilderness medicine next week. We got a bunch of fun topics that we'll talk about. And I think one of the days we're going to do backcountry fracture and dislocation management. We'll get a stretcher in here and we'll call some volunteers and let you guys get a little bit of hands-on experience with that. All right, have a great weekend.